Cerebral palsy, CP, is a group of permanent disorders of the development of movement and posture, causing activity limitations. Anatomy and pathophysiology, CP is due to brain lesions only, not spinal cord, peripheral nerves, or muscles. Critical periods of brain development, neurulation, weeks 3 to 4. Prosencephalon development, months 2 to 3. Neuronal proliferation, months 3 to 4. Neuronal migration, months 3 to 5. Organization, month 5 to postnatal years. Myelination, from birth to years after birth. Brain injury and CP. Injury can occur any time during development due to genetic abnormalities, toxins, infections. Vascular insufficiency, timing of injury influences CP type. 20 weeks, neuronal migration defects. 26 to 34 weeks, paraventricular leukomalacia. 34 to 40 weeks, focal cerebral injuries, prematurity and brain vulnerability. Premature infants are at high risk due to immature cerebral vasculature. Hypoperfusion in paraventricular white matter gives spastic diplegia. Vulnerable germinal matrix gives hemorrhages. Paraventricular leukomalacia PVL, symmetric ischemic white matter injury in preterms. May affect both legs more than arms, spastic diplegia, or one side more than the other, asymmetric diplegia. Intraventricular hemorrhage IVH classification. Papau grading system, grade I, germinal matrix hemorrhage. Grade 2, IVH without ventricular enlargement. Grade 3, IVH with ventricular enlargement. Grade 4, hemorrhage extending into brain parenchyma. Term brain injuries, middle cerebral artery infarcts gives spastic hemiplegia. Watershed infarcts gives spastic quadriplegia. Basal ganglia involvement gives dyskinetic extrapyramidal cerebral palsy. Types of cerebral palsy, spastic hemiplegic cerebral palsy. Usually due to unilateral brain lesions, often involving the left middle cerebral artery. Associated with hemibrain atrophy and parencephaly. Common in preterm infants due to asymmetric paraventricular leukomalacia. Spastic diplegic cerebral palsy primarily affects premature infants. Caused by intraventricular hemorrhage or paraventricular leukomalacia. In term infants, cause may be unknown or multifactorial. Spastic quadriplegic cerebral palsy, 50% prenatal, 30% perinatal, 20% postnatal origin. Associated with extensive brain abnormalities, hydrocephalus, diffuse atrophy, multiple cystic lesions. Linked to perinatal asphyxia or hypoperfusion injuries. Has the poorest prognosis among spastic types. Dyskinetic extrapyramidal cerebral palsy, formerly linked to kernicterus. Now mostly due to hypoxic ischemic injury. In absence of hypoxia or jaundice, metabolic or neurodegenerative disorders should be considered. Classification of cerebral palsy by muscle tone and motor pattern. Spastic CP, features of increased tone, hyperreflexia, clonus. Dyskinetic CP, features of involuntary movements. Ataxic CP, features of poor coordination, mixed CP, show spastic plus dyskinetic features. Hypotonic CP, rare, have overall low muscle tone. Monoplegia, rare, usually one limb affected. By body area affected, spastic hemiplegia 20 to 30%, one side of the body. Spastic diplegia 30 to 40%, mainly lower limbs affected. Spastic quadriplegia 10 to 15%, all limbs and trunk affected, by function, mild, minimal limitations. Moderate, partial independence, severe, dependent for care. Risk factors, maternal factors, intellectual disability, seizure disorder, thyroid issues. Long menstrual cycles, prior fetal losses, pregnancy factors. IUGR, polyhydramnios, multiple gestation, male fetus, third trimester bleeding. Twin death in utero increases risk for surviving twin. Perinatal risk factors, prematurity, choriomyositis. Face presentation, birth asphyxia, must be linked with acidosis, encephalopathy, spastic quadriplegia or dyskinetic CP, sentinel event, low Epker score, and organ damage. You must know that low Epker alone is not sufficient to diagnose birth asphyxia. Postnatal risk factors. CNS infections, meningitis, encephalitis, intracranial hemorrhage. Hypoxia ischemia, for example, from meconium aspiration. Persistent pulmonary hypertension, and kernicterus. Signs and symptoms of cerebral palsy, delayed motor milestones in the first year of life. Abnormal muscle tone often begins with hypotonia, later progressing to hypertonia. Early hand preference may indicate hemiplegia. Asymmetrical or absent crawling, growth issues such as failure to thrive. Increased reflexes, persistent primitive reflexes. Abnormal gait posture at the hip causes flexion, adduction, scissoring. At the knee, causes valgus or varus stress. At the foot, causes toe walking and hindfoot deformities. History and initial presentation, developmental delay, especially gross motor delays in the first year of life. Early hypotonia gives later hypertonia, a common progression. Longer hypotonia may lead to more severe spasticity. Early hand preference, suggestive of hemiplegia. Asymmetrical or absent crawling, growth failure, and persistent primitive reflexes are common. Comprehensive history, prenatal, includes maternal health, infections, substance exposure, trauma, and family history of neurological disorders. Perinatal, covers gestational age, delivery type, Apgar scores, neonatal complications. Developmental, focus on motor, speech, and social milestones. Social or educational, review early intervention, therapy use, academic performance, and assistive device needs. Physical examination, tone abnormalities, hypotonia, followed by spasticity. Primitive reflexes persist, e.g., Moro, asymmetric tonic neck, palmar grasp. Joint contractures and gait abnormalities, for example, scissoring. Hyperreflexia, clonus, and Babinski sign indicate upper motor neuron involvement. Spastic CP in 75%. Signs, hypertonia, spasticity, increased reflexes, and persistent primitive reflexes. Subtypes. Spastic hemiplegia, one side affected, arm greater than leg, early hand preference, possible seizures and vision issues. Spastic diplegia, legs more affected than arms, common in preterm infants. Spastic quadriplegia, all limbs involved, often severe with oromotor issues, cognitive impairments, and seizures. Dyskinetic extrapyramidal CP seen in 10 to 15%. Features: involuntary movements, fluctuating tone, poor postural control. Common findings: oromotor dysfunction, hearing loss, normal intellect in many cases. Other forms: hypotonic CP, generalized low tone with persistent reflexes. Mixed CP, combination of spastic and extrapyramidal features, monoplegia, single limb involved. Other diagnoses must be considered: cognitive and sensory issues. Intellectual disability, speech-language delay. Vision and hearing impairments, oromotor dysfunction. Diagnosis: no definitive lab test exists for CP. Diagnosis is based on clinical features, with imaging and labs used to rule out other causes. Lab tests, such as thyroid function, ammonia, lactate, and chromosomal analysis. Ultrasound, useful neonatally for unstable infants. CT scan, identifies hemorrhage or malformations. MRI, preferred for detailed brain evaluation and prognostic insight. EEG, used if seizures are suspected. EMG, assesses nerve or muscle disorders. Treatment approach, requires a multidisciplinary team, neurologists, physiatrists, orthopedic surgeons, geneticists, therapists, pulmonologists, and others. Movement disorder management, medications. Baclofen, diazepam, botulinum toxin, or phenol injections, anticonvulsants for myoclonus. Levodopa, benzodiazepines, anticholinergics for dystonia or chorea. FDA warning: botulinum toxin may rarely cause systemic effects. Surgical interventions: intrathecal baclofen pump, reduces spasticity, especially in trunk or lower limbs. Selective dorsal rhizotomy, reduces spasticity by cutting sensory nerves. Orthopedic surgery, corrects scoliosis, hip dislocation, and limb deformities. Alternative therapies, limited evidence supports effectiveness of complementary treatments like cranial osteopathy. Legal and ethical considerations, determining birth-related causes of cerebral palsy requires strict evidence and most cases have prenatal origins. Long-term monitoring, lifelong follow-up through multidisciplinary clinics ensures management of growth and nutrition, respiratory function, learning and development, spasticity and seizures. Medication management. Goal: reduce spasticity, improve function, and prevent complications like contractures. Most drugs are used off-label in children and require experienced medical oversight. 1. Neuromuscular blockers. Mechanism: block acetylcholine release, gives temporary muscle paralysis. Examples: obobotulin toxin, FDA approved for children with lower limb spasticity. Onabotulin toxina, off-label use in children, dose titrated based on muscle response. 2. Muscle relaxants. Mechanism: inhibit reflex pathways in the spinal cord. Examples: baclofen, oral or intrathecal. Useful but limited by CNS side effects. Dantrolene, reduces calcium release in muscles. Reserved for severe spasticity. 3. Benzodiazepines. Mechanism: enhance GABA activity leading to CNS depression and muscle relaxation. Example: thiazepam, effective for spasticity and seizures. Sedation is a common side effect. 4. Anticholinergic agents. Used for tremors, drooling, and dystonia. Example: trihexyphenidyl, reduces tremor and secondary symptoms by affecting dopamine pathways. 5. Dopamine prodrugs. Mechanism: enhance dopamine signaling. May help with motor control. Example: levodopa or carbidopa, mainly used in Parkinson's but may benefit select CP patients. 6. Anticonvulsants. Used for seizure control in CP patients. Examples: levetiracetam, oxcarbazepine, valproic acid, phenobarbital. 7. Alpha-adrenergic agonists. Mechanism: reduce spasticity via spinal reflex inhibition. Example: tizanidine, centrally acting relaxant. Metabolized by the liver. Management recommendations: early nutritional assessment to avoid failure to thrive. Physical and occupational therapy to promote mobility, prevent contractures, encourage independence. Speech and feeding therapy for oromotor dysfunction, regular monitoring for epilepsy, growth and nutrition, mental health and learning. Complications: orthopedic and physical, contractures, hip dislocation, scoliosis, decubitus ulcers, osteoporosis. Nutritional and gastrointestinal, feeding difficulties, risk of undernutrition or aspiration, gastroesophageal reflux disease, constipation, need for feeding tubes in severe cases, dental, caries, enamel issues, malocclusion, gingival hyperplasia, respiratory, aspiration pneumonia, chronic lung disease, bronchiolitis or asthma, neurological, epilepsy, more common in spastic quadriplegia, worse outcomes with neonatal seizures or multiple drugs, hearing loss, visual impairments, strabismus, visual field deficits, retinopathy of prematurity, cognitive and behavioral, intellectual disability, learning disorders, ADHD, autism spectrum disorders, low self-esteem, depression, sensory integration issues. Prognosis varies by type and severity, 25%, mild to minimal limitations, 50%, moderate to functional but dependent, 25%, severe to non-ambulatory, require full care. Sitting by age 2 is a good predictor of future walking. Not sitting by age 4 often predicts inability to walk. Life expectancy, mild CP, near normal, severe CP, reduced, but improving with better care. For more like this, follow, like, comment and subscribe. Find us on YouTube at Enchiridion-MD, Instagram at Enchiridion.md, TikTok at Enchiridion.md. You can also send a DM to get the physical copy of the Enchiridion guidebook. The Enchiridion app is also available on Google Play and iOS stores.